All right, since it's noon, we're going to get started. Thank you for joining us today for our Principles and Practice of Population Health Research MedTalk. I'm Daryl Kaw, the Director of Good Samaritan Hospital Foundation, and on behalf of all the staff at the Samaritan Foundations, we are grateful for your support and for joining us today. Before we begin, just a friendly reminder to mute your mics and to please turn off your cameras during the presentation. Please note that the presentation is being recorded. We will have time for a question and answer session after the presentation. I also want to thank our corporate pride partner, Epic, for their generous support and partnerships. Epic supports all the foundations at all the 5 hospital sites. And now it is my pleasure to thank and welcome Paulina Kaiser, Director of Samaritan Health Outcomes Research and Evaluation. Hi, Paulina.
Hello. Thank you so much for having me, and thanks to everybody for being here. So I think I'm just going to jump right in. I will start with kind of a quick introduction about myself. I always like when speakers talk kind of about their journey. And then I'll share a little bit about academic perspectives on population health, as well as ongoing projects that highlight some of the population health research we've been doing at Samaritan. So first, a little bit more about me. So I am from the Northwest originally, moved to the Midwest for more than a decade, and I'm very happy to be back in Corvallis, or back in the Northwest. But while I was in the Midwest, I went to graduate school at the University of Michigan to get a master's in public health, and then a PhD in social epidemiology. So epidemiology is the academic field within public health that focuses on patterns and causes of health outcomes in human populations. And then social epidemiology is the subfield that focuses on social, political, cultural, economic circumstances that affect population health outcomes. So I moved to Corvallis in 2014, sorry. My husband was doing his residency at Samaritan, actually, and he still works for Samaritan as well. I actually moved to, or worked at OSU first, and was a postdoc and instructor in the College of Public Health for a couple years, and then joined Samaritan in 2016 and have been in my current role as Director for Research and Evaluation for about a year now. So with that kind of just a little bit of background about me, so I wanted to kind of dive into what is population health research and what are kind of the academic frameworks and perspectives around population health. So first, got to start with the definition. I like this one from the New York Department of Health because it emphasizes that population health is about groups of people, but even though populations consist of individuals, that population health is more than the sum of the health of individuals in a given population. And so this is an important distinction to keep in mind, because there are ways to improve population health that aren't about working with people one-on-one to improve individual health outcomes. So this is where social determinants of health have come in. If you've heard that term before, we'll definitely talk more about that. Okay, so why does population health matter? So this is my favorite example. So in 2013, the Institute of Medicine put out this big long report called U.S. Health in International Perspective. So I want all of you to kind of think of what subtitle you might choose for a report on how the health of the U.S. population compares to the health of populations in other countries. So the subtitle that the Institute of Medicine chose: Shorter Lives, Poorer Health. So hopefully it's not a surprise that population health in the U.S. As a whole is not great. And here's another visual to illustrate that. So this graph shows the correlation between health spending per capita on the x-axis and life expectancy on the y-axis. And you can see for most countries, there's a pretty clear correlation between costs between health spending and life expectancy. And then you see the US as a very clear outlier over here, both for spending way more money than other countries per capita, and also for not having a particularly good life expectancy. You know, our life expectancy is comparable to Chile and the Czech Republic here. So this data is from 2013, but I assure you that the US is not spending any less money on health these days, and our life expectancy has not increased substantially since then. So the natural question is why, and what can we do about it? There are lots of contributing factors for sure. But one of the major theories is that the US spends relatively more money on curing disease late in life and relatively less money on preventing disease throughout the life course. So how can we kind of reframe and reconsider what's important when we think about interventions to optimize population health? So this is the health impact pyramid, which if you've taken a public health class, you probably saw this at some point. So this was described by Tom Frieden, who was the head of the CDC under Obama. So he called this a framework for public health action. So a way to think about which kinds of interventions are going to give us the most bang for our buck when thinking about kind of the trade-off between population impact and the level of individual level effort required to deliver interventions. And the takeaway here is that the most impactful types of interventions for public health target the bottom of the pyramid here, right? So socioeconomic factors, changing contexts to make default decisions, healthy decisions. I want to be clear, this is not to say that there is no role for counseling and education and clinical interventions. If I get sick or break my leg, I definitely want my doctor to provide appropriate clinical care. But there are limits to how much clinical interventions can do to maximize population health. So it's still important, but not sufficient in and of themselves to optimize health outcomes. And Frieden addresses this in the article, actually. So he uses the example of blood pressure control. So high blood pressure is a major health concern. It's a major risk factor for heart attacks, stroke, heart failure, and it's something that doctors know how to treat and manage. And yet, only about half of people with hypertension have it controlled. And this is despite the fact that of the people that we know who have uncontrolled hypertension, the vast majority, most have health insurance, have a regular source of care, and have multiple contacts with the health system. So clinical interventions and counseling here are not sufficient on their own to address this issue. And as Frieden says, to increase the impact of clinical care on population health, improvements in the third and fourth levels need to be implemented more effectively. To really amplify the effectiveness of clinical interventions, we need the conditions and the context outside the doctor's office to support the interventions that happen inside the doctor's office. So this importance of the context and kind of the broader social forces in determining population health outcomes really kind of highlights why population health science is a separate field of study from individual health. So this is a snapshot of the cover of my favorite population health textbook. And the authors do a really good job of kind of tackling this distinction early on. So they say in population health, we are interested in why some populations have more sickness than others, not why particular individuals within a population are ill. Why some people get sick and some don't is of less interest than why some populations have substantial cases of sickness and some have few. So in this book, they go on to describe 9 foundational principles of population health science. I'll come back to some of that in a bit, but I want to talk a little bit more about what it means to explore why some populations have more sickness and some populations have less sickness. So this is a graph from a paper that was published in 1985, which feels ancient, but so this is using data. So this data from Kenyan nomads was originally published in 1967, and the data from London civil servants, this is from the Whitehall study, was published in 1974. So these are not particularly new ideas, but this graph shows the distribution of blood pressure in these two populations, and you can see in both populations there are individuals with high blood pressure and with low blood pressure, but that overall the distribution of blood pressure for Kenyan nomads is lower than blood pressure among London civil servants. So if you were to ask about determinants of blood pressure within just one population, so you'd say, okay, just within the London civil servants, what are some of the reasons that one person has high blood pressure and somebody has low blood pressure? You could ask that question and you would find differences, right? You would figure out that, well, some people put salt on their beans and toast for breakfast every day, and some people walk to work, while others commute by subway when they go to their office job in a major metropolitan area. And so you would find differences between individuals that are real and true differences in why some people have high blood pressure and some people have low blood pressure. But if instead of asking the question about individual level differences, you ask the question, why is the distribution among the population of London civil servants different than the distribution of blood pressure among Kenyan nomads? You ask the question about the differences between populations, you would get very different answers, right? The answers, the characteristics of these two populations that contribute to these different distributions are going to be things like physical activity patterns, family support and social structure, perceived stress levels, exposure to nature, consumption of plant-based foods, right? You're going to get very different questions when you ask a population level. You're going to get very different answers when you ask a population level question. So when we ask questions at the population level, we open ourselves up to recognizing and understanding kind of a whole new set of influences on population health outcomes. And then the other thing I want to note here is about data. Epidemiology is a quantitative science, so I'm always thinking about the data. So you hear these sayings like what gets measured gets managed, or if you can't measure it, you can't improve it. And one of the persistent challenges in population health research is data, right? We have oodles of data about individuals, lots of data at the individual level. But data about populations is often harder to find, especially about the characteristics that are not just aggregates of the individuals within the population. And sometimes it's even hard to articulate, much less find validated assessment tools for the concepts that you're interested in measuring at the population level. So that's absolutely one of the major challenges in population health. But again, the more that we're at least thinking about these things and trying, I think we're going to get better at that. And we have, for sure. Oh, going back to the book, so I mentioned that they outline 9 principles of population health. I'm only going to talk about 2 of them. You'll just have to read the book to learn about the other 7. So I'll introduce them briefly here and then talk a little bit more about each of these. So the first, large benefits to population health may not improve the lives of all individuals. And then the second, efforts to improve overall population health may actually be a disadvantage to some groups, and whether equity or efficiency is preferable is a matter of values. So first, large benefits to population health may not improve the lives of all individuals. So this one I think is a little bit funny and kind of counterintuitive to think about, especially in a medical clinical context that's entirely based on optimizing individual health outcomes. You also hear this called the prevention paradox, but the idea is that lots of things that make a difference at a population level don't make much difference at an individual level, right? So reducing blood pressure by just a couple millimeters of mercury, reducing your BMI by 1 kilogram per meter squared, not going to make a huge difference at an individual level. If that applies to an entire population, it can make a big difference. This also applies to interventions like car seats. So 99.99% of the time that you strap your kid into a car seat, it's not going to change the outcome, right? So first of all, there's a very small chance that you're going to get in an accident. And there's an even smaller chance that you'll be in an accident severe enough that it would have caused injury. And there will still be very rare, but severe accidents where a car seat isn't enough to prevent the injury. So again, 99.9% of the time, whether you put your kid in a car seat or not is not actually going to change the outcome of taking a trip in the car. For some people, it may never make a difference in their life. But at a population level, we've seen substantial reductions in morbidity and mortality related to motor vehicle accidents since car seats were introduced. So this idea of scaling things that don't feel important at an individual level can be really important at a population level, and vice versa. Can be counterintuitive, but I think is a really important kind of idea to wrap your head around with population health. Okay, so how do we think about targeting interventions if the goal is to maximize population health? So this is a simplified representation of blood pressure in a population, a nice pretty bell curve. And so a common approach, especially in kind of clinical context, is to define risk groups. So we say you're at high risk or you're at low risk based on, in this case, blood pressure readings above some threshold. And if we screen you and you are at high risk, then we're going to do something about it. We're going to tell you to change your diet, exercise more, give you a prescription, whatever it is. If you're at low risk, we're not going to do anything. We're going to say good job and then move on to something else. So this is one of the frameworks, the approaches for targeting interventions. We call it the high risk approach, which is where you figure out who's at high risk and then target your intervention only to those people. So this type of intervention works really well under two conditions. So one, that we can define risk well, that people who are identified as high risk are actually pretty likely to go on to develop the disease or experience some adverse health outcome. And conversely, that people who are identified as low risk are not very likely to go on to develop the disease. And two, that there are successful interventions to reduce the risk in those who are high risk. So this is the high risk approach, where you only target people who are identified as high risk. In contrast, there's another way to think about intervening in a population, which we call the population approach, where the goal is to intervene on everyone in the population and just shift the entire distribution down. So this approach works well when the intervention is related to those lower levels on the health impact pyramid. So things like changing socioeconomic conditions, changing context to adjust default choices. So the goal is that everybody is affected regardless of their risk level, and that everybody benefits a little bit. So this is the population approach in contrast to the high risk approach. What happens, or what has been observed to happen sometimes, is that the effect of a population intervention isn't always uniform across the population. And so sometimes you notice this effect of actually just increasing the spread in risk. And what this can mean is that people who are at high risk actually don't benefit as much, and that most of the benefit, most of the reduction in risk is in people who weren't really at high risk to begin with. So this has been observed when the intervention is something that requires some degree of proactive engagement or uptake from individuals. And what we see is that people with socioeconomic disadvantages or other socially structured types of constraints are less able to take advantage of these new opportunities and new resources. And not coincidentally, these same people are often subject and more likely to be at higher levels of risk or exposure. So that kind of leads nicely into the second principle, that efforts to improve overall population health may be a disadvantage to some groups. And there is a clear trade-off between equity or efficiency. We're living right in the perfect example of this, which is COVID vaccination. So clearly the most efficient approach to vaccinating a population is these mass vaccination events, like this picture on the left, right? You take over a stadium for a day and you can get thousands of people vaccinated in one day. But there's a trade-off with equity with those approaches, right? Not everybody can make an appointment online, can get themselves to the vaccination site, can take time off during the day, have the flexibility in order to get there. So other types of interventions, other approaches, like doing the mobile vaccination buses, like this one from New York City, can do a lot to promote equity, right? And reduce some of those barriers to uptake for getting the vaccine, but you're not going to get thousands of shots in arms in one day through a bus. And so I think this also points to there's no right answer here, right? It's not a choice of one or the other. It's about balance, and it's about being able to kind of articulate the values and define what compromise we're going to be is going to be acceptable. This also brings us kind of to the importance of working upstream, which is language you hear a lot, about trying to focus on interventions that really realign the forces that shape health-related opportunities to be more equitable. So this is a figure from the de Beaumont Foundation that shows that the need for medical intervention and clinical care are really these downstream consequences of broader forces that are relevant to health even before they cause disease. Again, the healthcare system exists to help people who are already downstream. and that is a very important service to provide. But I think a lot of people recognize that clinical care is not actually addressing the root cause of these issues. And so the more that we can be kind of thinking and trying to move a little bit more upstream in the way that we are addressing these issues, kind of the more likely we are to be successful. And then the other language that I wanted to introduce here is fundamental causes, which was a term that was introduced to explain the remarkable persistence in health inequities over time between lots of different social groups. And the idea is that to really reduce disparities between racial ethnic groups, socioeconomic groups, we need to acknowledge and rectify the differential distribution of money, power, knowledge, prestige, social connections, all of these big, knotty, troublesome issues that really protect health. So, for example, it's all well and good to identify racial disparities in maternal mortality and to work to improve access to prenatal care and to reduce provider stigma. But at the end of the day, those interventions are necessary but not sufficient to counteract a lifetime and really multiple generations of subtle and not so subtle forces that create those disparities. And even if we are able to fix maternal mortality, Black women are still going to be more likely to die of breast cancer, of heart disease, of lots of other conditions where we see those disparities. I'm not going to be able to solve racism in the next 40 minutes, but I want to at least mention that, kind of end there, because it highlights this goal of really zooming out on a lot of the health problems we see and trying to understand what are those really upstream factors, the underlying factors that are limiting people from achieving optimal health. So on that note, I'm going to move on to talking about a little more kind of grounded information about what's going on at Samaritan related to population health research. I do want to start with the caveat, as I've mentioned. Medicine, clinical care is focused on improving patient health one patient at a time, not the default perspective in a healthcare system. Population health is not the default perspective. Population health is never going to replace the emphasis on patient care, but I think it is becoming more relevant, and there's a lot of pressure on healthcare systems nationally, and internationally, although anyway. So we're kind of moving away from this fee-for-service payment model to value-based payments and alternative payment methodologies. The Oregon Health Authority is really pushing the CCOs around the state to be leaders in thinking about transforming the health system to better integrate social determinants of health, health equity, and to be thinking about population level determinants of health. So it's kind of not a default, kind of a lot of new explorations going on in how health systems can really engage with this work. So couple of examples that I will touch on. So one, an COVID antibody study that we did with the support of Samaritan Foundations. And then ongoing work related to creating a housing strategy, and then also towards building out, increasing the availability and use of social determinants of health data. COVID antibody study. So official title was Regional Prevalence of SARS-CoV-2 Antibodies. As I mentioned, this was funded by the Samaritan Foundations. We were in the field for about 3 months with this study late last year under the guidance of two of our infectious disease physicians, Dr. Brady and Dr. Patel. And the goal was to estimate the prevalence of COVID antibodies among Samaritan patients. And there were a lot of different ways we could have gone about that. And the approach we decided to use was to recruit patients who were coming to lab draw stations to do routine or to do blood work ordered by their physician. So as a little reminder, if you can take your head back to late 2020, so there were no vaccines. The only way to have antibodies was to have been infected with COVID at some point. Also, PCR testing had still been pretty restricted for most of 2020, and that was back when we were still doing the nasopharyngeal swabs that had to touch your brain, basically. So there was kind of a not super enjoyable, and there was a lot of sampling variability in whether people were able to kind of get back far enough. And so we know that with the nasopharyngeal swabs, one of the concerns is a high false negative rate due to some of the and then again, just the demographics. So again, the early infections with COVID were predominantly in older adults, a lot of outbreaks in nursing homes, but by kind of summer and fall, we were seeing more cases in young and middle-aged adults. So what do we do? So we recruited patients from 4 of Samaritan's 5 hospitals. We didn't go to North Lincoln because we realized that most people there were actually going to Newport to get their blood drawn anyway, so we just went to Newport. So for patients who consented and agreed to participate, we asked them just 2 short questions. So we asked if they had been diagnosed with COVID, since lots of other providers were also doing COVID testing. So we knew that the information we had in our medical records was not comprehensive. And then we could put it in order so that the phlebotomist could just draw an extra tube of blood, again, while the patient was there to get their other to get blood drawn for other purposes. Our target sample size was 1,000 patients, so we wanted to get 300 from Lincoln and Benton counties, 300 each from Lincoln and Benton, and then 400 from Lynn County, which is the largest population of our service area. So I asked for some pictures of research in action, and this is what I got. So this is, on the left is Tony Franklin, our clinical research manager. I think he's studiously reviewing the informed consent document here as he's waiting to talk to patients at one of the lab draw stations. And then on the right is the Abbott Architect machine in the Lebanon lab that ran all of the antibody tests. So this was a totally homegrown type of project. So led by our local physicians and funded by foundations and executed with our clinical research team, and all the tests were done in Lebanon. So, okay, so in the end, we were able to test 920 patients, and we knew that we wanted to compare our study population to the entire active patient population, 200,000 people, because we knew that patients who were coming to the lab draw stations for blood work were not going to be a representative sample of all Samaritan patients, and we just wanted to be aware of what those differences were. So as we expected, we found our study population had more patients over 60, more likely to be on Medicare, and had more chronic conditions. Again, all of this kind of makes sense in that older patients with chronic conditions are more likely to need regular blood work, and thus to be at a lab draw station where we were recruiting. Antibody results. So of the 920 people we tested, we found 12 people who had COVID antibodies. So this was 1.3% of our study population. We'll talk more about that in a second. Even with the relatively small number of positives that we had, we did still see some regional variation, with the highest proportion testing positive from the Lebanon hospital and the lowest proportion at the Newport hospital. Okay, other interesting things we discovered. Of the 12 people that had detectable antibodies, had positive levels of COVID antibodies, only 5 had documented PCR confirmed infections, and 1 had been hospitalized, in fact, with COVID symptoms, but had tested negative twice. And then half had never been tested for COVID. And of those 6, 2 had COVID-related symptoms in their medical records, but had not been tested. And 4, so a third of the people who had antibodies had not been tested, didn't remember being sick, had no indication of potential infection. And we also found that there were 3 patients who had PCR-confirmed infections documented in their medical records, but tested negative for antibodies. Notably, the quantitative result from the lab was not 0, but it was below the threshold for a positive result. So I think on this test, the quantitative threshold was like 1.4, and these patients were scoring antibody titers of like 0.5 and 0.6, stuff like that. So there was some antibody response, but not enough to trigger a positive result. So how does this compare to kind of what else we knew. So again, we found 1.3% of patients had antibodies. That was less than half, or less than half of those had prior confirmed infections. Another way to think about it is that the number of patients with COVID antibodies was actually 1.5 times higher than the number of confirmed infections in the medical record. So at this time, again, at the end of last year, Samaritan had documented COVID infections among 1.7% of our active patients. And OHA, which is kind of the gold standard here, since they're taking in information about all of the COVID testing that's going on, reported a cumulative population incidence of 1.9% for Lynn, Benton, and Lincoln counties combined. And again, it makes sense that OHA's number is a little higher than Samaritan's because we know that Samaritan was just one of many providers doing COVID testing. If you're curious, I was curious, so I looked up what the number of COVID infections that Samaritan has documented as of yesterday, and it was 17,633. So more than 5 times the number of infections that we were at last year. So that's fun. Okay, so things that we learned. One, diagnosed infections undercount total infections. Infection doesn't always lead to robust antibody response. These are things that were definitely consistent with previous research, but we've never kind of quantified it locally. I think this was also a really interesting or a good study in that it demonstrated our kind of ability to do these large and complex studies. And again, this was entirely homegrown to kind of conceptualize and execute this. But there were a lot of moving pieces involved with this. So we had to work with, coordinate with a lab in Lebanon, with the patient registrars at each of the lab draw stations, brief the phlebotomists so they knew why these orders were going to be showing up, talk with the primary care docs who were seeing the antibody tests ordered on their patients and didn't know why. So again, there's a lot of pieces that were involved in kind of being able to complete the study successfully. On to the second project I wanted to talk about, which is the housing strategy task force. Earlier this year, kind of senior leadership authorized a task force to draft a housing strategy to coordinate and optimize efforts to address housing issues across Samaritan. So this was partially in recognition that housing is a major challenge in our area that affects health in lots of different ways, right? Kind of as a spectrum, from the need for supportive housing for homeless folks to mold abatement for kids with asthma, to even just like systematic processes for screening and being able to connect people to existing resources in the community. And also, lots of different areas at Samaritan have already been doing this kind of work for a long time. So primary care clinics, the care coordinators and health navigators provide support around housing needs. Care Hub definitely does a lot of work. Foundations has been involved with the patient support program. Community Health Promotion gives out social accountability grants to community service, to community agencies during providing social service support. And IHNCCO again has care coordination team, has some funds for health-related services, and has been doing lots of other work kind of in this area. So this work is still ongoing, but kind of these themes around ensuring robust systems for referring patients to community resources, expanding screenings for social determinants of health and social needs in the primary care clinics. I'll touch more about this later, but this is a really hard thing to do. And then also increasing access to short-term recuperative housing for houseless patients being discharged from the hospital. And also this emphasis on awareness and alignment across kind of all the different divisions at Samaritan. And then part that I'm excited about is that we'll be building in an evaluation plan to make sure that we can measure and track the impact of kind of all of this work. And then last, I wanted to talk a little bit about efforts to increase utilization and access to data on social determinants of health. There's actually 2 new tools that are being rolled out to capture and track information. One is built into Epic, which is the electronic medical record system we use. And the other is with Unite Us, which is a tech company that has built a platform to create a local network of resources to address social service needs. So this is a blurry screenshot of what EPIC looks like, if you've never seen it. So EPIC, what you can see here, EPIC released a module for social determinants of health data that we have integrated into our version of EPIC, sometimes called the wheel for perhaps obvious reasons. But the goal is to provide kind of a quick visual summary of social risks in 11 different domains. And if you hover over one of them, you get a little pop-up that shows you kind of the history of previous screenings, which is really great for putting this information kind of front and center and making it really easy to digest where there might be opportunities for providing additional support. And then the other tool that Samaritan's working on is Connect Oregon. So again, so Unite Us is the tech company that built the platform, and then Connect Oregon is the local network that we are part of that serves, I think it's currently 12 counties in Oregon, and you can see the list of major partners there, including IHN and CCO. So Connect Oregon is great because the idea is that a healthcare provider can identify a need for food assistance or transportation assistance, and they can go into Unite Us and send out that referral, and then social service agencies can see that and take up that referral, follow up with that person, and then close the loop so that the provider can find out whether that person was able to get the help that they need. So, yep, platform for closed loop electronic referrals between healthcare and social service agencies. So IHN is leading the rollout of this one as well. And so one of the challenges with both of these, and in general with integrating social determinants of health data into clinical systems, is the need for workflows and assigned responsibilities, right? There are a lot of competing demands for limited time, space, and resources. If we're going to be doing the screening, we also need to make sure that we have appropriate follow-up, that we have resources and assistance to provide, and facilitating referrals related to social needs is still dependent on buy-in from community agencies that also have a lot of competing demands, and again, just the availability of resources. But again, I'm really excited because the data, when we work through these workflows, the data is going to enable some really interesting research projects and really allow us to dig into kind of these population health perspectives and better understand determinants of population health outcomes. So that's actually all I had to share for today. So we will have a good amount of time for questions, which is great. So a few concluding thoughts to wrap things up. One, population health research is complicated. Hopefully I convinced you of that. But this process of asking and then analyzing, having data to analyze population level questions is a big challenge. Being intentional about balancing efficiency and equity and thinking about the interventions and their impact. And again, trying to stretch to better understand how upstream factors are influencing health outcomes. And patient care is always going to be paramount for healthcare organizations, but I think that population health perspectives are increasingly relevant. And really, Samaritan, I think, is just getting started, and it's going to be really fun to see how far we can go with this in the next few years. All I had, and I'm happy to take any questions or comments. You're also welcome to follow up with me by email. I have my personal email there, as well as shsresearch@samhealth.org, which also comes to me, but maybe easier to remember. So thanks again for being here, and I'm going to stop sharing. So happy to
I was going to invite anyone. You can put a question in the chat if you want, or raise your hand and we'll try to find you. I wanted to, in the chat, Paulina, I was going to list the text that you referenced, population health science. I put it in there. I noticed it's available on Barnes & Noble and Amazon and Google, and hopefully you can order through your local bookstore. But my question is this, I'm really interested in it, but is my brain going to be able to handle the information in that book?
Yes, yes.
Okay.
I would say I have a copy of it at home. I should have brought it in. Yes, I'm happy to wax poetic about the virtues of that book. Yeah, so it's like a paperback and it's pretty short and it is very digestible. It's actually intended to be a textbook for kind of intro types of classes in grad school. So I mean, it's academic, but it is approachable and digestible, and it's not super intimidating.
Perfect. Okay. Let's see if we have any hands up. I always have lots of questions, but I'll wait and see. I do, while we're waiting for people to think about their questions. So one of the things that the foundations receives, we've received quite a bit of requests for actually blood pressure cuffs around the system. So when you were talking about blood pressure and that area of need, and different levels at clinician and trying to have people give them cuffs if they can't afford it to monitor. And so I'm really curious about, do you know of examples where a community population health strategy was put into place to address with high blood pressure?
Yeah, I think I think it's really about trying to build kind of multifaceted sorts of, a comprehensive case. And so I think like blood pressure cuffs, like that can be really helpful for getting a sense of what people's blood pressure is when they're not in the doctor's office, right? Because maybe when you're sitting in that small room with the guy in the white coat, like maybe that's not a reflective measure of your blood pressure. And so I think blood pressure cuffs can be really helpful for, and again, it's like capturing that data that is a more accurate reflection of what's going on outside the doctor's office as well. So I think that's definitely like an important piece of it, but it's also just realizing that telling somebody their blood pressure is high is not always going to be effective. And so then the more that we can also be working on making fruits and vegetables cheap and accessible in grocery stores, and promoting healthy food options at workplaces and in schools, and these broader determinants of that influence population health outcomes that are not just reliant on individuals to understand and be making spending the energy and time to make changes for themselves, but thinking about how can we again zoom out and be thinking about ways to shift that distribution at a broader level. So I think blood pressure cuffs can be a part of like that kind of broader portfolio of ways that we target blood pressure.
Yeah, I know. I just brought it up just because it's such a need that we have seen, and I know that's just kind of like, that's like you said, that's like after the fact. We should be getting at the beginning, the root cause, and I can also see how important it is to look at just even like public school health and nutrition all the way through high school and that kind of thing of what we're doing to train kids and healthy styles. But anyway, do we have any questions? Yes, Aaron, let me know. All right, can you see those, or do you want me to read them?
Yeah, thanks, Erin. Yeah, Erin used to work with Lynn County Public Health, so she said Lebanon Hospital participated in the sodium reduction project. Yeah, environmental change strategy. Yeah, so in public health circles, you hear people talk about policy systems and environmental change, PSE change, and again, so that's how do we change the environment so that when individual people go on with their daily lives, as we all do, how can we kind of align those little nudges to be a little bit more towards the healthy side, right? How do we make the default choice the healthy choice?
Mm-hmm.
And there's lots of ways to be creative in thinking about that. Oh, Ursula. So Ursula said, if you could create the perfect healthcare system, what do you think is the ideal balance between population health and taking care of people who are already sick and injured? What would that look like for Samaritan if you were king? Oh man, I feel like I'm going to talk myself out of a job here. So yeah, so I think the key word there is balance, right? And you're never going to be able to prevent all of the need for clinical services, and I think it's also important to recognize that Samaritan as a healthcare system is really just one player, and there are lots of other organizations that spend lots of time and energy thinking about how to optimize population health outcomes. I mean, obviously our county health departments are going to be a huge part of that too. And I think there's a lot of public health infrastructure that's also working a lot on population health. So yeah, I mean, I think it's a good question about what exactly is the role of healthcare systems like Samaritan. And I don't have a like magical, super clear-cut answer. I do think that I think that a lot of the kind of like external pressure related to these like value-based payments and the shift away from a fee-for-service model in healthcare, I think that is really kind of bringing a little bit more weight to like, oh yeah, we really need to be figuring this out, and that Samaritan as a healthcare system really does have a responsibility to engage in those proactive sorts of interventions in order to prevent, subsequent disease. And at the same time, again, it's not something that Samaritan is able to achieve on its own. So it's always going to be a balance, and it's always going to be about partnership, I think. And Andy says, how typical is it for population health interventions to account for population level moderators? Yeah, interesting question. Andy, I don't know if you want to jump on and explain more about what you mean by population moderators. I could take a stab at it, but I'm curious if you could describe that a little more.
Yeah, sure. I mean, I'm thinking of, often in individual intervention approaches, there's a question of what's going to moderate the individual level approach. So I was just curious, as you were talking through the population health interventions and thinking particularly about how some individuals will not gain from it, whether there's still some, okay, within population-wide, this intervention is going to probably work for most people, but here's also another population for which it may really work or not work at all.
Yeah, that's a great question. And so this idea of like, so you did research, you found something that works in one population, then how well can you kind of generalize those results or apply those same results to different populations? And we do this at the individual level too. And so it's a question about moderating is the terminology, because you're asking is that kind of cause-effect relationship moderated or changed by certain characteristics? Yeah, it's a great question. And there are a lot of examples of interventions that work in one community that do not work in other communities. And it's in some ways, it's kind of harder at the population level because you get into a lot of like social psychology and like the sociological dynamics of influence. And so, yeah, no, I think it's a great question. And, again, this is the entire field of implementation science of trying to understand why do some interventions work some places and not others. I think it also comes back to the data challenge, right? Is that to detect those in a statistically significant way in a regression model, you need to have data and you need to be able to quantify all of that stuff. And a lot of times, we do not have that kind of data. And so you will see people kind of like thinking about what those types of factors may be, but I think often it's really hard to quantify that in a satisfying way.
Yeah, that's super interesting. Thanks.
Yeah. And Katie says the 3 levels of prevention. You want to talk more about that, Katie? Like primary prevention, secondary, is that what you're talking about?
Yeah, I was just commenting when you were talking to Ursula about how to create that balance, I mean, you can put prevention in any level of care, really.
Yeah. Yep. Yeah, that's a good point. Yeah, so primary prevention being kind of before there's any indication of disease, and then you can have secondary and tertiary prevention as well, kind of later disease stages. So yeah, that's a good point.
I have a question about, so with EPIC and the module that you were showing us, so are you going to be able to pull population data through that system? Okay.
Well, again, we'll pull data on individuals that we can aggregate to the population level, yes.
Oh, so you have to pull each individual.
Yeah.
And put that, okay.
But even that, I mean, I have to stop myself from salivating too much about the potential with that data. So, and again, the workflow issues are really challenging, and that's something that it's going to take a while to figure out how to best integrate that into all of the other demands, especially in the primary care clinics. But yeah, I think it's going to enable us to better understand how, like in a very local context, how these types of social needs and risk factors relate to health outcomes and could eventually help then inform some of like the risk stratification processes that we use, some of the outreach, help motivate some of the prevention types of interventions that we are doing. And also, again, just to be able to track, like, if we can identify these needs, can we actually help people resolve these needs? And, you know, we know that these things are important for health outcomes, yeah, I mean, all the time. And so, again, if we start getting some data on that, getting some visibility on that, then we can actually see if we're able to help people get what they need.
And when you're saying it's just a process, you're saying like, so if somebody sees an ACE-DOH concern in the clinic, what is the clinician supposed to do with that? Like, what happens next?
Yep.
Right. Just brass tacks, like.
Yeah. Yep. And so that's, I think Unite Us is actually going to be part of the solution to that, so that the care coordinators can follow up and send referrals that are needed. But it's also, you know, it's time and energy to like ask these questions. They can be kind of sensitive questions, so you want to make sure that you're creating a kind of respectful environment, and you have the time to really follow up on any of the, you know, kind of vulnerable information that's going to be revealed. And yeah, and then definitely follow up. Who's responsible for that follow up? Who's going to make sure that that it happens? Yeah, because if we're gonna, you know, if we're gonna ask, we want to be able to follow up and to provide some assistance. So.
Okay, I have one more question. I know I'm hogging, but I don't see any in the chat. So any interest, or would you learn anything from the 12 positive antibody individuals that you previously studied and where they are now?
Oh, that's a good question. Yeah, so we have learned a lot about COVID since last year. So I think, so one, we could retest those antibody levels and see how the quantitative level of the antibody has changed over time. So that's something that we're seeing now with this movement towards needing booster shots, right? Is that there seems to be some waning antibody levels over time. It's still, and I should say I'm not an infectious disease expert. I haven't stayed 100% up to date on all this stuff, but like, I think there's some interest in what is the natural history of that decline, and how does the decline in antibody levels over time differ between people who have immunity from infection compared to people who have immunity from vaccination. So yeah, there's a lot to learn. So yeah, and I, you know, again, it was just because, you know, back to that point about following up. So part of the study was that Tony, our clinical research manager, who's also a nurse, actually called all 12 of those people on the phone afterwards to tell them that they tested positive for antibodies. It doesn't really change anything. There's no like treatment, or there's nothing to do, but just to explain that they're positive and what it meant. And I remember him talking about how some people were just like so totally surprised and had no idea. So yeah, there could be some interesting things to learn from follow-up, but the whole landscape of COVID in our service area has changed substantially in the past year. So.
Well, I don't see any more questions. I just want to say I know I can speak on all the foundation's team and staff. Is like, we are so impressed with what you and everybody does with research. I mean, there's so much happening with Samaritan that people don't know about, the clinical trials, these experiments, and just learning about just through this whole COVID pandemic, different techniques and treatments that are being explored to see how we can help our patients. It's actually super amazing. And so we thank you for your time and all you do for Samaritan, and thank you for your presentation today. We appreciate it.
Yeah, thank you for the opportunity, and thanks to everybody for attending.
Right. Thanks.